My name's Chris Smalley. I work in consulting now. At the core of who I am, I'm a clinician. I used to work, I had a private practice. I worked in the field doing school-based mental health. I came in from doing school-based into management at the nonprofit I was working at, built their compliance department, built their QA department, and then eventually went into county work with Summit County and worked as an auditor for them. So I have a lot of experience in the compliance area, in the documentation area, in the clinical area. And I still always go back to feeling the pain of clinicians. We keep changing things as clinicians. We just don't like you people messing with us whenever you change the rules. Like, can I just see my clients? So I get it. And how many clinicians are in the room today? Do I have like, okay. Do I have, who are billing people? Oh, man. So you guys are always dealing with us difficult clinicians who just want to do it our own way, and I apologize. We want to serve our clients. That's why we went into that. And then agency leaders, is that the remainder of the? All right. So today, I'm here to talk about quality assurance and clinical documentation. I've done this as an all-day presentation. I'm going to try to keep it in the 30-minute box because I'm a rule follower that way, which is why compliance worked for me. That being said, you do have a flyer on your table about my consulting firm. As you're looking forward at outcomes, I have a data guy, I have an outcome guy, I have an ASAM lady, I have auditing people, and we can help you out if you need help. If you have questions, Sonda happens to be my ride back north, so feel free to email me. My contact information is on that form and on here, so I'm going to have to peace out with her when she is ready to go. So we're talking about quality assurance plans and clinical documentation. This is nice because this is kind of a break from what you've been talking about, all the details. We're going to look at it from the top. All the things that you have talked about already today are meaningless if you don't have good quality documentation. I have a couple notes I want to make sure that I hit. And that quality documentation is only going to come from you guys setting up some kind of quality assurance program. At some point in everybody's work, documentation gets looked at. But it's not always a formalized process. How many, just a show of hands in the room, how many of you guys have a formalized quality assurance plan or program? Okay. You're a step ahead. There's lots of agencies I work with that don't. That doesn't mean they're doing bad work. They just haven't formalized the process, and they're not always doing a good job being forward-thinking about what they need to have set up so that they're monitoring what's happening. I'm clicking here. I'm not clicking at the thing, huh? I got it. So your quality assurance planning for your clinical documentation. What is it? How's it going to help you? As you're looking forward and starting to plan for all the strategic planning that Chris is going to talk about later, the value-based purchasing that the MCOs are starting to talk about, if you can start to set your quality assurance plans up so that the things you're measuring and the things you're looking at are proactive instead of being reactive as an agency. For the last probably 5 or 6 years, agencies have been very reactive, terrified about the changes and kind of running in response to that. Well, now a lot has been laid out for you today, what the future is kind of going to look like. So when you go back and you start to look at your QA plan, think about those things and how you want that to look. So what is your QI plan? It's a formalized plan for systematic monitoring of your clinical documentation. Your QA plan likely covers your entire agency. I'm talking today about your clinical documentation. So it's that formalized plan of how are you going to look at things and what are you going to do with the data. The plan's used to determine if the agency documentation meets specific requirements. We all have requirements. It's part of the reason we're here today. We hate requirements, but we have requirements. And I think that lately it's become really easy to villainize the MCOs. Like, oh man, they make it so hard, it's so awful. And really, I've had conversations with so many of them, and at the heart of what they're doing, they just want good care for their clients, just like we do. I have yet to go to an agency, like I said, that's providing bad care. We're just not doing a good job of showing that we're providing that great care. Your QA plan can help be the foundation for that. Your plan establishes measurable goals for your agencies in their clinical documentation. Your plan should help identify agency trends and inform your training agendas. So many times we have the plans, and we have the plans because Carve requires it, or because COA requires it, or because the state says I have to, or my local board says I have to report quarterly. But what are we doing with that data at the agency level? And I know that that's hard, because a lot of times it's some clinician that's brought in from the field that sets up the programming. I was that girl. It was terrible. I didn't do data good. It was hard. That's how you say it. I don't do data good. It's not me. I don't do it. But you have, whoever you put in that position that's kind of in charge of the QA planning has to learn to do data good. But what are you going to do with it? You can have reports. You can push them out to your staff. That's meaningless if you're not actually doing anything with it. And the best thing we can do now is, if you're planning your goals, that you use that information to inform your training moving forward. A strong QA plan not only improves your services delivered to clients, it increases your reimbursement, and we are all about that. Especially if we have coding people and billing people in the room, that's your guys' job. So we want to take it back and share with the staff, what can we do to keep pushing the reimbursements up? And it reduces your agency risk from audits from the outside. You're doing internal chart reviews, I'm sure. Does everybody here do internal chart reviews? Yeah. But what are we doing with that information? And are we formalizing that process? And what are we doing with the data? Sorry, wrong way. When we're planning, and how can you make your plan meaningful? The first thing you want to do is establish some solid foundations. You need a focused initiative each year. When you start out with your QA plan, you guys have to decide what you're going to measure. But my best suggestion is that you pick, as an agency, what's a quality initiative that you want to tag on to that. Like, do you know that your assessment narratives really aren't up to par? And some of you know it because you're not getting those prior auths through. When you send the assessment and the MCOs are looking at that assessment and saying, this doesn't prove medical necessity. I don't know what this is even, how are you providing this service for this client at this time based on this assessment? So if you know that's a weakness, then make that your quality initiative. Something that you know is a problem in your agency at the get-go, make it your quality initiative. Communicate your plan to all of your staff. A lot of times when I go in and work with agencies, I find out that they have a QA plan. It's great. It looks awesome on paper, but the only people that know about it are the CEO and the head managers. They know what it's supposed to do, but if it's not being pushed down to all of your service providers and your staff and your billing, nobody really knows what we're doing with it. It's just a pain in the butt that we have to go and we review charts, or I have to pull charts, or I have to do a plan of correction on this chart. But why? You have to talk about what your plan is and how it's going to help your agency. We're in a place right now with our agencies that we're ripe for a paradigm shift and a change in the climate. We have to start to talk about reintegrating our clinical documentation into our clinical work. So you talk about it, and then implement it by using the results to inform your training schedule. That is one of the most useful things you can do with your QA plan. A lot of times, the only thing that I see QA plan results used for is to go ahead and keep a grant, or to prove that we're doing PQI or QA, whichever agency you're being certified for. But there's really no other reason that it's being used. So this is something that's real concrete, that you can take your data, you can make it meaningful to your staff, to your agency, to your director, to your county board, to your MCOs, and all of your big stakeholders. And it's going to make your documentation be more individualized as well. And then share your report and your results in a way that makes sense to everybody. If you're handing out a spreadsheet to clinicians, I would have looked at that and dumped it in the trash as I walked away from my mailbox. I As a clinician, when I was in the field, I don't want to see a spreadsheet. I don't care about that. Show me a graph with a percentage on it or a pie chart, something that's meaningful to me. You have to know your audience. Your board, if you're a nonprofit and you're presenting your data to your board, they might like that spreadsheet because there's usually a lot of finance people and lawyers on boards. You have to know your audience, make your data meaningful, and make your people get engaged. One thing that I love to do whenever I go in and help set up a QA plan with agencies is talk about historically what has been the outcome. What do you do with the information? So your charts stink, your charts stink, your charts stink. Yours is pretty good, and that's all we know. Nothing is done beyond that. And knowing your staff is so important at that point because you can go, all right, let's set some initiatives in place. So if we're setting our compliance rate at 95%, every clinician that hit 95% compliance on the tool that we use to review the charts goes in a drawing for a $5 Starbucks card or a $5 Dunkin' Donuts card. And then you talk about it. Like, 10 of you made it into the drawing. Here's the person that was drawn this month. Way to go. Good luck to everybody next time. And have your performance improvement plans in place for the people that aren't meeting your expectations, but really looking in a positive way at the people who've done well. That's a big difference in how we historically have talked about QA plans and the outcome of chart review is really kind of incentivizing it. We all like to win stuff. There was somebody I was talking to that wanted the Keurig so bad. I'm sorry you didn't get it. We love to win stuff. So if I'm in compliance, I'm going to get my name in the drawing, and maybe I'm going to win. And it helps start to at least change some of that conversation about documentation being the absolute worst thing that I have to do when I'm doing counseling. So when you're setting up a plan, as an agency, setting up a focus group that helps to determine well, first of all, your specifications of what are you going to measure? Are you looking to measure your requirements for the state? Are you looking to measure your requirements for your certification agency or your accreditation agencies? Or are you looking to measure something at your local board? My recommendation would be that you measure what the state's going to come in and look at and adding on anything else that you think is important, like your accreditation. That should probably be there if there are some different requirements. JCO, Joint Commission, has a lot of different requirements than COA and Carve, so making sure that you're looking at following those rules when you set up your tool. What's your compliance goal? If you know, if you put your tool together that you're going to use and you have all your check boxes of the items that you know have to be in the chart, all of your quality initiative items, so you have the time, the date, the place of service, the precipitating event that brought somebody to their treatment, their medical necessity is all in there, and you go through all the pieces that we go through in chart review, and then you have your quality initiative of did the assessment contain the things that we want to see, because you might have some things at an agency level. And you kind of look at that and you said, I think that probably we're at 75% overall as an agency in compliance. When you set your compliance goal for the quarter or the half or the year, you don't want to set your compliance goal at 95% because everybody's going to feel like a failure. Nobody's going to feel successful. We're never going to get it. We're never going to get there. So pick a reasonable compliance rate that you want to hit. If you think everybody's at 75%, set it at 80, knowing you want to move towards 95% compliance, because that's what we're always looking for, is that 95% compliance. You need to think about how frequently your agency will want to review. Most agencies have quarterly requirements, but does that take somebody away from their job for too long? Do we want to break it down into months? Do we want to do it in group supervision, if that's your style? How is that going to work best in your internal processes so that you're getting the information you need and you're able to push it back out in a timely fashion to your staff, so then it's more meaningful? Who's going to be responsible for your reviews? Is this all going to be laid on one person? Are we going to spread it out among the supervisors? Is staff going to be, line staff going to be responsible? Are we going to pull some billing folks in because they know what's going on too? As an agency, you've got to decide how you can integrate as much of your staff as possible. That's my best recommendation because we're looking to change the climate, make documentation less of a burden in my head as a clinician, make it more meaningful. I know that clinicians go to school, we know documentation's important, but we still, as a whole, most clinicians don't really like to do it. So how can we make it as meaningful to them as possible? And engaging them in that review process and the QA plan helps them see how it fits into everything. How will your reviews be completed? My best recommendation is get it electronic. If you're doing it by hand, somebody at some point is going back and tallying all of those with tally marks and then making, doing math, a percentage, and trying to present that for at the clinician level, at the team level, and probably at the agency level. So that's a lot of hand calculating that can be eliminated. There's nothing out there right now. I do, however, it's a premature plug, but I do have somebody coding a program, so I'm really excited about that. But it's surprising to me there's stuff for E&M codes and things like that, but there's nothing out there right now that helps us keep all that information in one place. Best bet is electronic. That would be my first recommendation. Figure out some way that you can do that electronically. If paper is what you have to go with it. And then deciding what you're going to do with your results and how will you manage the follow-ups. That's the piece that falls off. We push the reports out, we're done with it. We say, you know, you needed to get signatures on your treatment plan. You needed to get signatures on a consent because there wasn't one. I don't know how we've been providing services, but there was no consent. But then the follow-up a lot of times falls off. If you can set up a form, something that shows that you're giving to each supervisor who has those clinicians on their team or to the individual clinician that they have to give back to you. How are you going to follow up and make sure that those corrections made? Because you've done the hard work. You've reviewed it. You've assessed the document. You've assessed the record. And now we found out what needed fixed. 2 years later, somebody reviews that same chart again. It comes up in chart review, and that stuff wasn't fixed because there's no follow-through. And that's a lot of dedicated staff time, I understand that. But moving forward, those kind of things, we're just not in an environment or a climate anymore that those kind of things can fall off the charts. It's going to have to be followed through. And for our prior authorizations, a lot of the things that you're looking at in chart review are so important that they get taken care of if they weren't taken care of properly on the front end. Implementing your plan should be more than chart review. I keep saying chart review. We all do chart review because we all have to do chart review. But are we missing the point? I've been doing a lot of talks lately about reintegrating paperwork into your clinical work because historically we've looked at it as an annoying add-on. I mean, of the clinicians in here, how many of you love to do your paperwork? Wah, wah. Nobody loves to do paperwork. I hear a lot of times, I love to do paper. The thing I love most about paperwork is when it's done. Yeah, absolutely. I love paperwork because I take that 10 minutes at the end of a 50-minute instead of having a client for 60 minutes. Those aren't the things we need to do anymore. And as we're trying to individualize treatment, we need to be looking at that in our documentation, and that comes in during this QI planning too. How can we pull it all together? A good QA plan sets the foundation for that great documentation. This is how we can make our practice more client-focused. As you set up what the items are you're going to assess in your QA plan, you need to be looking towards that client-focused practice, this client-focused documentation, the notes, the treatment plan especially. I'm having a hard time not going to clinical documentation today because I've done so many trainings lately on clinical documentation. But that's what these guys are, that's what the MCOs are looking for. That's what they want to see. Is this service individualized? And you've got to build it into your QA process. That has to be something you're looking at. Does it look like it's individualized? This is where you can get all your staff involved, like I said before. And this is where you're able to prove that your services are changing people's lives. You guys are doing great work. Doing great work. You're helping people. You're doing it because you're passionate about it. You're obviously concerned about doing it well, or this room wouldn't be so full. This is where you can prove it. You can say, we capture all these things in our clinical documentation. And you're only capturing what's happening. So as you're showing the progress in your clinical documentation, you're able to show client progress as well. Your QA plan is a lot like your treatment plan. It needs to be dynamic. You have to review it. If you just have the same plan forever, and a lot of agencies, you get it set up, it's a pain, you get it in place, you get your review tool in place, and 5 years from now, somebody goes, hey, didn't that rule change? Why are we still looking at it this way? That's not even the requirement anymore. It has to be dynamic, just like your treatment plan for your clients is dynamic. Things change, their situations change. The last year has made it so evident that in our field, things are changing and the rules are changing. Sonda was talking about rules that are changing. Teresa was talking about rules that are changing. The other Teresa was talking about rules that are changing. We've got to make sure that our tools stay up to date. The one thing that I would keep the same is your quality initiative. So if you decide we want our assessment narrative to look a certain way, these are the items we want on top of, over and above, or how words that we always want to see, or how we want the dimensions on ASAM assessed, and you've done that training with your staff, and you put that in place as a quality initiative, you need to keep that for at least a year so that you can see the progress, and that your staff, I almost said your clients, because sometimes it feels like you're doing a treatment plan when you do your QA plan and you do your training plan. But you want to keep that quality initiative in place for a year so you can see the change over time. You can see the progress. You can give kudos to your staff for making progress. You can feel good about it. But even more importantly, as your documentation has gotten better, the process has gotten easier for prior auths and appeals. You've been able to prove medical necessity. You've been able to demonstrate the golden thread to a T. And that makes your reimbursement so much easier. It makes you so much easier, so much more fluid, and you're going to get more back. You're not going to have to spend time appealing as much if you get the prior auths the first time. And if your plan isn't helpful, you need a new plan. That's pretty self-explanatory, but again, it needs to be meaningful to you at the agency level. So I've spent some time talking with some of the heads of the MCOs in the behavioral realm, and they have a lot to say. And it's things that you need to hear. So it's kind of a little bit more than what we had talked about, but I had a summary of the last conversation I had with the whole group of things that they really want you guys to know, the things they really want clinicians to know in agencies. When you're sending paperwork into them, or if they're going to come and look at your documentation, what's happening right now with your client? Yes, historic information is very, very important. But when you're writing that document, when you're writing that prior auth, when you're writing that appeal, what's happening right now? Why this client? Why this service? Why now? Why should your client continue the services? As clinicians, we love to talk about how much progress our clients are making. They're doing so good. You're doing so well. You're making so much progress. I'm so proud of you. Keep going. And that's good. And we need to document progress. However, if your client still is in treatment and you're not keeping them just because they show up, if you're keeping them because the service is actually medically necessary, you need to continue to document why are they still there. What are their continued barriers to recovery, mental health or AOD? What's important that you're giving to them that their hairdresser or the bartender isn't? What are you doing different? Why this service? Why this client? Why right now? What supports are still needed? So you're talking about what continued barriers they have, what supports are still needed. One thing that I heard from them when I was talking to them was they want an update of what's happened in the last 30 days. Don't resubmit the same thing that you submitted at the beginning. What's different now? Our clients typically aren't static in their situation. They have some things that are static, but their life is always changing. Often it's very chaotic. What's different? What is their discharge or transition plan? And this is a piece that I think historically we've always said, discharge planning needs to start at assessment, but I don't think we've ever done a really good job of documenting that. In the AOD world, how many AOD providers are in the room? And the others are all mental health? Okay. I think that we've, especially in the mental health field, not done a lot of work around transition planning. Maybe discharge planning, like how will we know you're done? How will we know when you're done with your treatment? And we talk about those kind of things. But AOD now has so many levels in it that you need to be talking about the transition planning too, and mental health as well. Now, we just historically haven't done a good job at it. So what does transition planning look like? If I'm bringing you into residential, one of your treatment goals is that you're going to step down. What are we going to do with you? Where are you going to go? What's our plan? And that needs to be documented somewhere in your record. And they want to see that. They're all asking for transition plans. What is that? What is your client going to do next? And you can't wait until, if you know you have that first 30 days, or even if you get another 30 approved for prior auth approved, you can't wait until day 50 to start transition planning. That's not going to happen. Recovery housing doesn't come available that quickly. Their parent or whoever they're going home to, in using residential as an example, might not be prepared for them. They might not have a sober environment to go to, and 10 days sure isn't going to be enough. So that transition planning has to start at the beginning, and you have to be able to show it. Where did you write it down? Where did you talk about it with your client? Individualizing your notes and treatment plans, and we talk about that. We talk about it all the time. And those are things that you can pull into your QA plan too in your chart review process. If your client is seeing an outside psychiatrist or other provider, demonstrate what's happening in your documentation. And if you're that AOD provider that doesn't have it on site, that's also going to show some support in Dimension 2 and 3 for you whenever you're writing everything down. Make sure you're writing it down. Tell the client's story. If your client's receiving mat services, give a description. Is it on-site? Is it off-site? How's it happening? How are they getting there? How's it going? And discuss the psychosocial issues within their family so a reviewer can see what's going on in the client's system. Again, this can help talk about your barriers. What's going on? Well, the client's doing well, however, can't reintegrate with the family. We've watched it whenever the family comes in. Write those things down. Don't just write about the good. We want to hear about the progress. MCOs want to hear about the progress. Insurance companies want to hear about the progress. But why should they still be in your care? If they're doing so great, why should they still be in your care? Just because they show up? So those are things to consider. I'm at 29 minutes. So anybody have any questions? There's a lot of talking. I'm a fast talker.
Are you going to provide us with PowerPoint?
Yes.
Do you have any samples?
Do I have any samples? My contact information is going to be on here.
Okay.
Send me a question on what you need. And we can always spend some time talking too at the agency level. Are there needs that you have that we can help fill for you?
Everybody